Welcome to everyone who's attending in person and online to this meeting that will be presented by the Department of Gastroenterology. Our presenter is Vikash Lala, who should be known to everyone here. And so he's going to talking to us about making a comeback, big comeback in gastroenterology, making gastroenterology great again. Not that it was ever down there, but make it even greater. So we all know that Vikash is very passionate about advanced endoscopy and he's quite experienced in that field. And so yeah, we look forward to hearing what you have to say to us, Vikash.
Thank you, Dr. Seabi. Yeah, so, gastroenterology has had a couple of sessions during the year for these medicine meetings. And what we've tried to do is at least once incorporate a bit of endoscopy into our meetings. And while it might be a little bit irrelevant to the general physician audience, I think it's actually not. Because I think it's useful for the general physician to know what we do, what we can do, and in knowing so, know which patients to actually refer to us. But there's also a few other issues, and this is why we really chose this topic. And one of the issues is that there's this big misconception, and it's partly our fault for this misconception because there isn't a lot of exposure to gastroenterology, especially on the VIT circuit. So on the VIT circuit, a few registrars will have the opportunity to rotate through us. And often when they do, they come to us and they'll be like, wow, we didn't know you guys can actually do all of that stuff. It's actually cool. You actually can do a lot more than we think you can. And that's the problem, because the misconception is that the gastroenterologist is there to treat cryptosporidium-associated diarrhea. The deal is that the infection diseases doctors cause, and GERD. And our role is far, far bigger than that, especially in 2024. And what I'm really here is to give you a taste of that. So this talk might be very impractical for the general physician. It's really not big data. It's really not very special, interesting, rare cases. It's really what we do every day and what we are able to do in 2024. So the problem is, and how we picked up this problem is, you often have registrars rotating through our department or rotating through anywhere. And when you speak to registrars, you ask them, what do you want to do when you're done? Or why did you do medicine? And a common answer you hear is, I did medicine because I want to become an interventional cardiologist. Now, there's nothing wrong with becoming an interventional cardiologist, but the problem is, I've never heard a registrar come to us and say, I did medicine because I want to be a gastroenterologist or an endoscopist or an interventional endoscopist. And that's what we're here to change. So we're here to show you what we do, a little taste of how we do it, but to generate interest. So we want to show junior MOs, fellows, registrars, medical officers, what we can do. And we want people to start doing medicine and coming to us and say, this is actually quite cool, and I want to do this, and this is why I did medicine. So that's the point of this talk. So we do probe a lot of patients, yes, but unfortunately, that middle comic is not quite true because we don't take all of their money, just some of it, and arguably not enough, but anyways. So the point of this talk is really that it's really to make gastroenterology great again. And like Dr. Seabi says, it never was not great, but it's the misconception that most physicians have about gastroenterology, and we had to change that idea. So really the essence of this talk, and we focused on other endoscopic aspects in previous talks, like endoscopic ultrasound and things. So this one is going to focus on our oncological role. And it really has become a paradigm shift. And it's become a paradigm shift through innovation, through technical advances, through our ability to do more and more. So before, in terms of oncology, we were there as a bridge, as a damage control bridge. We would get referred patients who have metastatic disease, where you have no other way to get histo, and you really just want us to put the scope in to find a big fungating mass and take a little piece of tissue for you. That was our role before, but it really, really has expanded since then. So why has it expanded? Well, our first endoscopes were quite crude instruments. It was essentially a pipe that you'd put your eye in and look down someone's throat, literally through the pipe. There was no camera, there was no optics, there was no monitor. You literally had to put your eye over the eyepiece and look down someone's throat, or even worse, up someone's bum. And the problem with that is it gave us very crude imaging. And again, the crude imaging didn't allow us to do too much. It allowed us to just pick up big lesions. and eventually take a little bit of a biopsy and get you your answer. But since then, things have drastically evolved. So the first thing we started doing to our scopes is we started making better cameras. So we increased optics, we put better lenses on our cameras, we put LED systems to ensure good light sources. We even added microscopes to our cameras. We can now zoom. We can zoom to such a good level that we have something called confocal laser endoscopy. And that's essentially doing microscopy in the colon. So we can zoom to such a great level that we can see cellular detail. And we can essentially make a microscopic diagnosis. Okay, that's still in its infancy and still being trialed in expert centers, but it's certainly coming. We've also monitored our lenses to enhance our optical images. So we enhance our optical image through two systems. It's either the lens or it's virtual enhancement. So it's post-process enhancement. So this allows us to filter out certain types of light. It allows us to enhance certain types of light. And in doing so, what we've achieved is a great amount of detail. So this is one of the newer generation scopes. And what you can see when we enhance light, especially red light, we can now see vascular detail, and we can see it with such great accuracy that we can see every fine little capillary. So the entire view that you're seeing is about 1.5 centimeters, and those finer capillaries are really, really tiny. But identifying these capillaries, analyzing these capillaries, analyzing the mucosal pattern, the villus pattern, the mucosal pit pattern, the vascular pattern, allows us to assess lesions with quite great or quite detailed accuracy comparable to histology. So we can make an optical diagnosis, which is often close to the histological diagnosis. So not only did we improve our lenses, someone decided, let's put the lens on the side of the scope. So now we can see sidewards as well. And that's allowed us to see different structures. For example, the major papilla. And that's essentially the idea of ERCP, because you can't see the papilla so well with the forward viewing scope, but you can see it beautifully with the side viewing scope. We then took it a little further, and someone decided, what if we stick an EUS probe on top of our scope? So now we have endoscopic ultrasound. And we know with ultrasound, the closer you are to the object of interest, the better you see. So endoscopic ultrasound has really changed the game as well, because now we can sonar you from the inside out, essentially. We can get into your stomach and look at your pancreas, which is just centimeters away. And we can see it with such great detail that it gives you far better image quality than doing a percutaneous sonar. But not only can we sonar the pancreas and see it, but we can also insert instruments. So on the right-hand side there, you see a needle. So not only can we see the pancreas, we can stick a needle into it, we can stick a stent into it, we can drain cysts, we can drain necrotic collections, we can do a whole lot more with endoscopic ultrasound. The next thing we did is we made a hole in the scope. So when I say a hole in the scope, I rather mean a hole through the scope. So this is what we call our working channel. And now this allows us to put toys down our scope or instruments. So with this, we can now put biopsy forceps, we can put clips, we can put snares, we can put a whole lot of devices, and this has really expanded our therapeutic armamentarium. So we can do a lot more, not just see a lot more nowadays. So part of the things that we can put down the scope, and I'll show you this in some videos, are knives. These are not actual knives, they're rather electrosurgical knives. This has given us the ability to cut and dissect as well, and with very, very good accuracy, and I'll show you this. We took it another step further. Not only can we put things through the scope, we can put things over the scope. So this is what you call an over the scope clip. So this is a clip that attaches on the outside of the scope. So it gives us a wider diameter. It allows us to do things like full thickness resections. We can cut off a full thickness piece of the colon or esophagus. And essentially when we do that, we're making a hole or perforation. But what we do is we close the hole before we make it. So we put a clip and we cut above the clip. So that hole never gets a chance to form. It's closed before we actually make it. We can put instruments on the tip which enhance our view. So those are distal caps. We took it even further. Now, not only can we put things through the scope, but we can add extra channels on the outside of the scope. So now we have a whole new port, a whole new accessory pathway on the side of the scope. And this has expanded our horizons even more. So this is an example of a suturing device. So now we can actually advance a suturing device, and we can actually suture holes and suture things closed. So this has allowed us to do endoscopic bariatrics. We can do a sleeve gastrectomy endoscopically, incisionless. We can make a hole through your stomach, remove tumors, simply suture the hole closed. So things have really advanced. And we have come a long way from being an operator that gets you histological diagnosis. So GI oncology, or our role as oncologists, is really, really evolved. And it's evolved essentially to all aspects of oncological care. So we're involved in prevention. How do we prevent cancers? Well, we prevent it by first finding early lesions and precursor lesions. So in the colon, we look for polyps. In the esophagus, we look for things like Barrett's or dysplastic squamous cell areas. In the stomach, we look for things like dysplasia and atrophic gastritis. We look for precursor lesions. We deal with them. In the pancreas, we can sonar cystic lesions. We can monitor them. We can look for high-risk features for cancer. We can even look for lesions like neuroendocrine tumors in the pancreas and in other organs like the liver. And because we find early lesions, we can now resect them very efficaciously, and I'll show you this with good degree of accuracy. And in doing so, not only can we find lesions, but we can prevent cancer. And that's probably our number one role. That's our real value. Not to diagnose or treat your cancer, but to actually prevent you from ever having a cancer. If it's a little bit further, we can still assist with diagnosis. And again, we can assist in two means. We can assist by optical diagnosis. So just by looking at that early cancer, by looking at that vascular structure, by looking at that mucosal structure, we can tell you that this is dysplasia, this is an early mucosal cancer, or this is a deeper submucosal cancer. We can tell you this is for us, this is for the surgeon. We can quite accurately stage cancers without even taking histo. But yes, we can, of course, take histology as well. Once we've diagnosed your cancer, we can actually stage you. So we're no more relying on radiologists as much. We can stage cancer locally, again, T-stage by just looking at the tumor. We can tell you how deep it is, often with a decent degree of accuracy. But we can also stage distant disease and local regional disease. We can put an EUS scope. We can look for nodes. We can look at your liver. We can look for metastatic disease. And in doing so, we can actually stage you perhaps better than even radiology. So often we get patients from the endocrinologist, for example, with the suspected insulinoma. Endoscopic imaging, or EUS, has become the gold standard for actually identifying or working up these patients. So often insulinomas are not picked up by an MRI or CT scan. And EUS has more accuracy at picking up these tiny lesions in the pancreas than even an MRI scan. So we can stage you, we can find lesions, and with greater degree of accuracy. We're relying less and less on surgeons and interventional radiologists, and we're doing things more and more on our own. In fact, the surgeons and the interventional radiologists are now turning to us for assistance with difficult cases. After staging, we can actually treat and potentially cure your cancer. And we can cure it so well, especially in early stage disease, that you don't sometimes need chemotherapy. You don't need invasive surgery. You get to keep your colon, you get to keep your esophagus, we get to preserve organ function, yet we can cure early cancers. And if all else fails, and if it's too late, we can still play a role in palliation. So if you have a tumor in your esophagus and you have lumen opposing tumors or lumen obstructing tumors, we can stent your esophagus, we can stent your duodenum, we can stent your colon, we can help you with pain control. Patients with pancreatic cancer who have intractable pain, we can do an EUS, find your celiac plexus, stick a needle into your celiac plexus ganglion, stick some alcohol in and lyse it. And that's an effective means of pain control for patients with intractable pain in pancreatic cancer. We can even divert you. So patients before who had obstructive pathologies, for example, a gastric outlet obstruction or malignant gastric outlet obstruction, either from a gastric cancer or duodenal cancer or pancreatic cancer, before those patients couldn't eat. And what you would have to do is send them to surgery for surgical diversion. The surgeon would chop off their duodenum and reconnect it to their stomach. The gold standard for that has now been endoscopic diversion. We can put an EUS scope in your stomach. We can find by sonar a loop of jejunum. We can burn a hole through your stomach, put a stent in your jejunum, and leave the other end of the stent in your stomach. We've diverted you. You can go home the same day. You can eat almost immediately. Less costs, less invasive, less pain, comparable outcomes. That's now become the gold standard for diverting patients with malignant gastric outlet obstruction. We can divert your biliary system. You have a distal biliary stricture or head of pancreas cancer. We can't get in and do an ERCP. Your system is obstructed. We put in an EUS scope. We find your big bile duct. We burn a hole through your duodenum. We put a stent in your bile duct in your duodenum. We drain you through your duodenum. We can put a stent from your stomach into your gallbladder. We can put a stent from your stomach into your left hepatic duct, so into your liver and in the hepatic duct. So we can drain your biliary system very, very well with low complications, and the surgeons are turning to us for these modalities as well. So all of that being said, there's absolutely no time to cover all of that. So really the focus of today is going to really be prevention and a bit of treatment. And I'm going to focus not so much on EUS, but I'm going to focus more on what we call endoscopic mucosal resections, or rather just standard gastroscopy and colonoscopy. It's not quite standard because these are advanced procedures, but in any event. So not only can we prevent by finding and by resecting pre-malignant lesions, not only can we treat cancer, but we can do it very, very well. We can do it with preserving organ function. So you don't need a hemicolectomy, you don't need a proctectomy, you don't need an esophagectomy. If we preserve organs, we maintain function. We can do it with low adverse events than surgery. It's less invasive, it's quicker recovery. You go home the same day or the next day. It's cost saving, and it has comparable long-term effects in terms of mortality. So this is just some data, and we're not going to spend time on this. It just shows you that surgery for benign pre-malignant disease is not without risks. Adverse events, around 20 to 25%. That's quite high. Mortality, about 0.9%. So 1 in 100 patients might die from non-malignant benign disease going to surgery. And this is what we should be avoiding in 2024. So yes, we do have complications as well, but our complication rate is lower. We can prevent you from having surgery in about over 90% of cases. Yes, we do have complications, but most of our complications are minor and are not treated surgically. Less than 1% of our complications require surgical management. And the argument has always been that our recurrence rates are higher because when a surgeon operates, cuts off an entire piece of your colon. When we take out your polyp, we're removing just the polyp. So yes, we're not getting as wide a margin. And the argument is that we have more recurrent disease. But there's newer techniques. And with newer techniques, our rates of recurrence are very low for polyps, 3%, 4%. Of course, it varies between centers. But even if you have recurrence, we can still treat your recurrence endoscopically in over 90% of the time. So we can really spare you from surgery in most instances. And not only can we spare you from surgery, we can save money as well. So this is a study that showed the mean cost difference per patient was $7,600 US. And we could save an estimated $10 million US. So we see shorter length of stay and cost saving. And you can see in the graph at the bottom that endoscopic therapy really is much cheaper than surgical therapy. So we prevent you from long hospitalization, from needing ICU, from relooks, from all of those complications. And it's not only for benign disease or pre-malignant disease. We also have very good efficacy for early cancers. So we can remove early cancers. And yes, we might have slightly higher recurrence rates, but we have comparable long-term mortality. So we can remove early cancers and essentially give you the same outcome as surgery. So how do we do this? The first thing in order to do this is to find these lesions. So we need to find precursor lesions. And this really is the role of screening endoscopy. So there's one metric that we use as endoscopists, and this is a key performance index. So if you don't meet this metric, you need more training, or you need more practice, or you need to change your practice. So one of the metrics we use is something called the adenoma detection rate. You pick up more adenomas, you're going to prevent more cancers. We also have a sessile detection rate. You pick up more sessile cancer, more sessile polyps, you're going to prevent more cancers. So that goes without saying. There's a lot of things to do a perfect colonoscopy and to find these lesions. So this is taken from a webinar from a foundation that's very dedicated to endoscopy training from Belgium. It's a foundation that I'm fortunate to be a part of. We do a lot of online teaching. But basically, to look carefully, we need many things like a clean colon, good basic technique, awareness of a whole lot of factors. But this is where technology has also come in. And now we're able to manipulate images to our advantage. And we're able to see a lot more and make a good optical diagnosis. So how do we manipulate images? So scopes have built-in systems, and these are now standard across any brand. Our scopes here do it. We do not have the latest generation scopes at Charlotte or even at Donald Gordon. But our scopes still have the capability, and all of the videos that I show you today are all done with our scopes, not the latest and high-end scopes. So we do this either through optical imaging, so the lens does something special, or processor-based imaging. So the processor, the step, enhances the image through a whole lot of techniques and virtually. And basically what it does is it filters certain spectrums of light. So for example, if you use an Olympus system, we have something called narrowband imaging. Narrowband imaging filters out green and blue, and it enhances red light. And by doing so, it helps us look at vascular detail as well as mucosal patterns. We can also spray things on top of the mucosa, which help highlight things. So we can spray things like methylene blue, indigo carmine, acetic acid. And this, again, helps us with our vision. So when we see a polyp, first we just look at it and we look at our overall impression. And there's a lot of features that can tell us this polyp looks scary, it looks like cancer, or this polyp is benign, and we can take this out. We then look at the morphology of the polyp. So does it have a little stalk? Is it pedunculated? Is it protruding and sessile? Is it flat and elevated? Is it depressed? Is it excavated? And that again dictates risk of malignancy. So this is an example of a colorectal polyp in somebody's cecum, and you can see the polyp there. There it's hiding a bit behind the fold, but here we've managed to open up the fold using this cap around the scope. And when we see that polyp, we get very close to it, and then we turn on our image enhancement. And when we turn on our image enhancement, you can beautifully see the fine vascular pattern on that polyp. That vascular pattern helps us tell you, is this an adenoma? Is this a sessile serrated lesion? Is this a hyperplastic polyp? Is there cancer in this polyp? Is there dysplasia in this polyp? And how deep is the cancer? So there's a whole lot of classification systems that look at the fine structure, the pit pattern, the shape, the vascular structure. There's Kudo classifications. There's the Japanese classification. There's a whole lot of confusing classifications. But we've also tried to simplify this. And essentially what we look at when we look at polyps is we look at for what we call a demarcated area. So we just look for one pattern that's different to another pattern. That's a simple way of thinking about it. And we know that these classification systems can be quite difficult. So what we've tried to do, and I've been involved with the team in Ghent in this study, we've just come up with a simple classification system. We just use terms like regular, regularly irregular, and completely irregular or irregularly irregular. And using those three simple terms, we can tell you what type of polyp is this? Is there cancer? Is it early or is it deep? So we've tried to simplify all of those difficult classification systems, and this is what it boils down to. So that's regular. That's regularly irregular. So it still has some pattern. That's completely irregular. It's lost all of the pattern, or it's amorphous like a whirlwind. That's an adenoma with no dysplasia. This is high-grade dysplasia or intramucosal adenocarcinoma. This is submucosal or deeply invasive cancer. And based on that, we can tell you that's for endoscopy, that's for surgery. However, this boundary is being pushed, and we're now starting to delve into that as well. And I'll show you a little bit of that towards the end. So again, we look at patterns. So there you can see a little area in the middle there that's demarcated. In that polyp, you can see another area there in the depression that's demarcated. In that polyp, you see another demarcation, but again, there's still some structure, so that's irregularly regular. This is completely amorphous. The pattern, that's deep cancer. That's deep cancer. And sometimes in one polyp, you can see all three patterns. You can see a regular pattern, you can see a regularly irregular pattern, and you can see an irregularly irregular pattern. So we now know if we see this, and even if we're sending to surgery, we biopsy there. If we biopsy there, we're getting an adenoma and we're misdiagnosing you. So let me just discuss two principles that we think about when we're doing resections. So the first principle is, do we take something out in pieces or do we take it out in one block? It's safer to take it out in pieces, because if you take it out in one block, you go deeper and you risk injuring the muscle layer, and then you can have a perforation. But if something is cancer, so if we take something out piecemeal in little pieces like that, the problem is if one of these pieces come back as cancer, the pathologist gets this piece and he can't put this puzzle together. So he gets this piece and he sees there's cancer on the margin. Trapped. Is it all out? Is it still in? What do we do? Do we now take you to surgery? Do we just watch you? It's now a bit of a guessing game. So when we suspect cancer, that's what we want. We want an unblocked resection. The surgeon bread slices the specimen. We know the cancer is there. We know the lateral margin is free. And we also know whether the deep margin is free. It's So this is the second principle I just want to introduce, and it's basically basic anatomy, right? So we know in the GI tract there's layers. The first layer is the mucosa, and it has different layers like the lamina propria and the muscularis mucosa. Then we have the submucosa. Then we have the muscularis propria with the inner circular and the outer longitudinal muscle layers. So essentially, pre-malignant lesions, adenomas, sit on the mucosa. As you start getting cancer, it starts diving deeper into the submucosa and then into the muscle. And as you go deeper, your risk of nodal disease increases, but also when we resect that, it becomes difficult to get it out completely, but that's changing. The submucosa, I tell my patients, is like a sponge. And when you put water in the sponge, you expand the sponge. So we've now utilized this to advantage. So remember, these layers are all in all about 4 millimeters, 6 millimeters. They're very, very, very small. So we can now take a needle, inject methylene blue and a crystalloid or voluven into your submucosa and expand it. It gives us more space to work with, puts us further away from your muscle, so prevents things or reduces the risk of complications like perforations. And again, this is the principles of cancer starting to go into the submucosal space. So these are T1B cancers, and when they go there, it's a T2 cancer. But even within the submucosal space, we even divide it into 3 layers, and this is prognostic. So let's get to what I think is the fun part of the talk. And if anything, again, this talk's probably irrelevant, but it's to show you what we can do. So if anything, you get to see some cool videos today, or at least what I think is some cool videos. So this is a colonoscope, and you can see that this colonoscope is actually flipped on itself. So actually, let's just go back and show you that. So the tip of the scope is bent to such extreme angulation that you're actually looking backwards. And this allows us to look at the back of folds. Previously, you just look forward, and you can miss things hiding at the back. So this was a patient with the polyp, which was referred to me, and it was concerned that this polyp was a malignant polyp because there was an area that looked depressed. It's not actually a depressed area, so that's the polyp there. So that's not really a depression, it's just a fold. So what we do is we look at the polyp, we see our first impression, and my first impression was that this is not cancerous, this is benign. We then get close to the polyp, and already you can start seeing that beautiful surface pattern. And this surface pattern is telling me that this is an adenoma. We get closer to it, we turn on our image enhancement, and we look at the pattern, and we can really quite well assess this. So this is a tubular adenoma without any dysplasia. This is an ideal target for endoscopic therapy. And of course, that's what we did here. We resected this polyp endoscopically, spare you from a right hemicolectomy. You get to keep your colon. I can't really turn that off anyways. You get to keep your colon. So I don't have the resection specimen here or the post defect, but I'll show you some more examples. This is another polyp in somebody's rectum. Again, this polyp was quite concerning because it's got a bulky component to it. So you can see there's a flat component, and then there's a big little bulky nodule there. And that bulky nodule confers a higher risk of cancer. So this is a polyp that I thought was a target for an unblocked resection. And I'll actually show you the image in subsequent slides and on how I remove this. But again, the scope is flipped back on itself. We get close to that mucosa, and you can see beautiful mucosal pattern. We turn on our image enhancement. We turn on something called near focus, which helps us look at closer objects with a greater degree of accuracy. It makes it much more crisper. And you can see fine capillaries on that structure. And if you analyze those fine capillaries, you can tell that this was a tubulovillous adenoma. The risk of dysplasia, it had a risk of dysplasia because of the nodular component, and that's why I chose an unblocked resection. So I could calculate that the risk of covert cancer or buried cancer that you can't see in this polyp was around 14%. This was a young patient. 14% to me meant something more aggressive. I did an unblocked resection. But we can do this. We can calculate your risk. We can do these things quite accurately in 2024. Another polyp, just overall impression, ugly, scary, bleeding on its own, and somebody took a bite out of it, or something took a bite out of it rather. So that always concerns you for cancer. Again, image enhancement. And now you see a demarcated area. So you see this area, that's regular. Then you see this area, that's irregularly regular. So that's early cancer. But then you see an ugly area, which is irregularly irregular, amorphous, that's deep cancer. When you biopsy this, you biopsy it here, you don't biopsy it there. This is invasive cancer. I sent this patient to the surgeon. But again, and the histo result came back as a T2 cancer. It was invading the muscle. So it was the right call. This was an invasive cancer. This was better served by surgery. If this patient was old, was there at high surgical risk, we could talk, because then we could push our boundary, and I'll show you how we push our boundary. So I could have potentially removed this, but I felt the best outcome for the patient was surgery, given that the patient was young, and so the patient went to surgery. We can do the same thing for Barrett's. This is a patient with Barrett's. So we know this is Barrett's. Let's just go back, sorry. You'll see pearly white, that's squamous mucosa. So that's what the esophagus should look like. You see the pink, that's gastric mucosa. Barrett's, gastric mucosa coming up the esophagus. Okay, so again, you're seeing the Barrett's there and the nice pearly squamous mucosa. So this is a long section of Barrett's. This patient was referred to me by the surgeons with an early Barrett's cancer. And you'll see that now, two ugly nodules. Those nodules are bleeding. You'll see the pattern on them. These nodules are cancer. But what was missed in this patient, and what is equally important, because you could go and cut out this cancer, and you could leave behind other things. And I'm going to show you what the other things are. And I'm going to show you how accurately we can actually do these things nowadays. So there, demarcated area, but there's still some structure, regularly irregular, early cancer, candidate for endoscopic therapy. But there's something more subtle as well. And the more subtle is there. So I park my scope on the more subtle. I look carefully at the more subtle. I turn on my image enhancement, and you can see what we would call a line of demarcation. So there's a line here. That's normal, but this area is different to that area. This area was high-grade dysplasia. That area needed to come out. If we left it in, it's going to turn into cancer as well. And you can see it's slightly bulky, it's slightly raised in comparison to the adjacent mucosa. And that's another clue that that was something abnormal. So what I did now is I sprayed acetic acid, essentially vinegar. And what that does, it causes acetylation of cytoplasmic proteins. It causes things to turn white, but it causes cancer to lose the white quicker. And the one thing that I'm a fan of that's not talked about in guidelines and not taught in gastro is I combine image enhancement plus my acetic acid. Look at that mucosal pattern. I can see a great amount of detail. And let me show you this area of high-grade dysplasia now using these combined modalities. Sorry. So now you can see an area of demarcation. You can see a line there. You can see that pattern is different from that pattern. These mucosal crypts are crowded. They bunch together. They're small. That's nice and wide open. That's high grade. And if you go to a hair or to a barber, you're getting a haircut. If you go to an interventional endoscopist, you're getting this, a resection. So what I proceeded to do was mark out the lesion. So you'll see these little dots. That's my roadmap. It tells me how far to cut so I can get a margin, because once I start cutting, things look a bit messy and it's difficult to see. And this was what we call an endoscopic submucosal dissection, basically stripped the mucosa and submucosa in about 60% of the esophageal lumen. That's the normal mucosa. This was a submucosal SM1 cancer. It was cured with the scope. Patient doesn't need chemotherapy. Patient has comparable outcome to surgery. Patient gets to keep his esophagus. Remember, esophagectomy carries a 4% mortality. Yes, the absolute risk here is not zero. So in theory, you still have a risk of lymph node metastases of less than 2%. You have a risk of dying. So with surgery, they still take out your nodes. We can't take out your nodes. But I know your risk of nodal spread is less than 2% based on the histology. You have a risk of dying of 4% from surgery. You have a risk of nodal disease of less than 2%. You take your 2%, you roll the dice, and you get to keep your esophagus and eat. And that's what the resection specimen looked like. So let's talk about some resection strategies. This is something called an endoscopic mucosal resection. And these are devices called a snare. It's just a little loop of wire. We have two types of snares. We have a hot snare and a cold snare. The cold snare cuts. It's a wire. It doesn't cut as deeply. It cuts more superficially in the mucosa. So less complications like bleeding and perforation, because as you go deeper, the blood vessels are bigger. But more recurrence rates and less deeper resections. The hot snare cuts with electrocautery. It's not a wire. The heat cuts. So you can get much deeper with the hot snare. This is just a small little polyp and a basic example of how we do a basic, simple polypectomy with a cold snare. We open that little loop of wire. We manipulate it so that it's sitting around the polyp with a good margin. So the polyp looks like a fried egg with the yolk in the middle, and we just chop it off. Easy, quick, takes a few seconds. And a potential cancer prevented. Okay, let's move on. This is a very subtle polyp. This is a polyp that we call a sessile serrated lesion. The reason why I know there's a polyp here is it's covered by mucus. These polyps produce mucus. When you find mucus in abnormal areas where the gravity isn't, you look for these polyps. So that's not the point of this. The point is just to show you basically how we resected this with a cold snare. So here I used a submucosal injection. So like I told you, we stick a needle into your submucosal space with some methylene blue, and we inject some blue fluid in there. And in doing so, we expand the submucosal space, but we also highlight the outline of the polyp better. So you couldn't see it before, but now you can see the border of the polyp. So now I cut wide enough so I don't leave any piece behind. I reduce the rate of recurrence because I'm able to appreciate the boundary of this polyp a lot better. So you can see the white there is the polyp, and that's the normal mucosa there. So that's the outline of the polyp there. That's the polyp there. So just injecting it and then whip it out with the snare quickly, safely. And you'll see that now. Let's move a little bit ahead. There's our snare. And this is a piecemeal resection because this was assessed to be completely benign. So very safe to take out piecemeal. You don't need to take it out in one block. You don't need to increase your risk of complications. You can simply chop it out in pieces. So this snare was a little bit deformed and a little bit defective. It's not supposed to look like that, but that doesn't matter. It's not the point here. I'm going to skip a little bit ahead to save a bit of time. You can see we can manipulate that snare. We can flip it left to right. We can put the tip in. We can control that snare beautifully. We can place it where we want to place it with quite a great degree of accuracy, and we can end up with quite good results in taking out these things with very low recurrence rates and very low complication rates. Still a bit of polyp there. And then we collect the pieces afterwards for histology. But we can accurately assess this so well that we're starting to sometimes not send things to histology because our endoscopic or optical diagnosis is so good. Okay, and at the end, you end up with a beautiful resection bed, beautiful defect. There's a little pieces floating in the water there. And that's the end result of polypectomy with a cold snare. Just want to show you what a hot snare looks like. So there you can see a big polyp. This is an adenoma. This one is big. This one is a bit more concerning. This one needs to come out with a hot snare, not a cold snare. I've already put my submucosal lift or my injection or whatever you want to call it, that blue cushion that I've put in there. I place my snare. You can see this snare is a thicker wire. It's not meant to cut. It's a burning snare. It's a hot snare. It's meant to burn. We cut with wires and we burn with ropes. That's what I teach the fellows. Capture a nice piece of tissue. I do a safety check. So I bounce the snare to see that it's nice and soft in my hands. Soft means submucosa. It means no muscle. It means I'm not going to get a perforation when I press the pedal and burn. I bounce the piece of tissue. It's nice and mobile. The whole colon doesn't move as a whole. I don't have muscle trapped in my snare. And I can take off the pieces off, blast it away with water. and then proceed to take off more and more pieces until it's done. So let's just skip a little bit ahead. Place my second snare. And again, you can place it quite accurately. You can manipulate it quite well. You can fine tune that snare. Of course, it requires a certain degree of technical skill and scope control and tip manipulation. And of course, it does require a lot of technical skill. But what I'm trying to show you today is that it's not just technical skill. We're not technicians. There's a lot of thinking involved in these processes as well. And that's something I try and teach the fellows as well. We're not technicians. There's a lot more teaching and thinking in endoscopy. And the best endoscopists are the ones that are able to think and not just do. Let's move a bit forward, taking off another piece there. And essentially we can clear that entire polyp. Okay, so I'm going to move on. Then what we would do is take the snare and we burn the border of this polyp, because if there's microscopic cells left behind, it reduces the rate of recurrency. This is a different type of polyp. So this is what we call a pedunculated polyp. It's got a stalk. Problem with the stalk is this big polyp needs a blood vessel to feed it. That blood vessel is running in the stalk. These polyps, one of the risks of resection will be bleeding. But we can overcome that. So here's what we call an endo loop. I'm going to call it a cable tie, because that's essentially what it is, and that's something we can all understand. I put a cable tie around the stalk, I choke the stalk, I squash the vessel, I cut above it. So this was quite a big pedunculated polyp. It was probably about 5-6 centimeters. This patient was going to go to surgery. But this is easily done, quickly done, efficaciously done. Again, you keep your colon, good outcome. So that's just, I have edited this video, so I did skip along there. But choking the stalk, and you can see the polyp turning white. It's getting ischemic already. I know I'm squashing that vessel. Okay. I'm closing my cable tie, and I'm leaving my cable tie behind. That will eventually fall off. The patient will pass it out. It causes no issues. Then I take my snare. I place my snare over the polyp. I ensure that I get a margin. So I place my snare over the entire polyp between the loop and where the polyp starts. So I get a good margin as well. And again, you can accurately do that and carefully do that and get an R0 resection with a good margin. This was an R0 resection. Just manipulating it, shimming that snare down that stalk, getting it close to that loop, but not too close so that when I cut, that loop doesn't fall off. And there you can see the cautery starting to happen. So this stalk, I don't want to quickly cut. I want to cook, because if there's a vessel and I haven't completely caught it, if I cook it, it won't bleed. If I transact it quickly, it will bleed. So we cook it, polyp gone, stalk beautiful, absolutely no blood except on the polyp. And you can see that little artery there. And that artery hasn't even had a chance to bleed. And that's the meatball that came out. So this is what's achievable with endoscopic mucosal resection. We can take off massive polyps, polyps that take up almost the entire lumen. Even if they do take up the entire lumen, that's the resection defect. This is another massive polyp. The resection defect is basically about 80% of the circumference. Another huge polyp, massive resection defect. Another big pedunculated polyp. This polyp was basically blocking the entire lumen of the colon. And that's the resection defect for taking that out. So that's more for benign disease when we're taking things out in pieces, but we can use that also for malignant disease and trying to unblock. But then we've taken it further. So now we have something called endoscopic submucosal dissection. Now we have knives. Knives allow us to cut things out in the block. So these are some of the knives that we use. I commonly use that one, whatever. You don't need to know about the types. But this is the principle of an ESD, or endoscopic submucosal dissection. You have a lesion, you can do different approaches. You can cut the mucosa open around it. You can put your submucosal lift in the submucosa, and you can dissect underneath it and take that off. Or we can do what we call a pocket approach. So we open the mucosa on the one end, we dig the scope underneath it, above the muscle layer in the submucosal plane, we dissect underneath this lesion, we then open up the mucosa in the back end, we free the mucosa on the sides, and we take the piece of tissue off. And I'm going to show you this as well. And this is what we can achieve. So these are all cases that we've done. So this is an early rectal cancer. This is a malignant rectal polyp in someone's rectum. This is big surgery. This is a mesorectal excision, whatever you want to call it, the low anterior. This is quite morbid surgery. This is hard surgery. This is difficult surgery. This is complicated surgery. This is a colostomy bag. Use the word bag to a patient, they're going to jump to the endoscopist to prevent the bag 99% of the time. But you can see what we did is we took out an unblocked specimen, and this is the defect. On the defect, what you're seeing is inner circular muscle. And you can beautifully see that circular fibers. This is what came out. It was an early submucosally invasive cancer, no bad features, endoscopically cured. This was probably the biggest polyp I took out. It was literally like a burger patty. I couldn't even get this thing out of the anus. That was one of the big challenges, taking the actual specimen out of the bum. Surgeon wanted to dilate the rectum. I was like, please, let's not dilate the rectum. This was a massive polyp, massive defect, taken out endoscopically. Funny enough, this patient originally was from Belgium. It looks like this polyp followed me from my training in Belgium, removed with an ESD. Another malignant polyp. This is the one that I showed you, that picture with that nodular area. That's the defect. That's the specimen that comes out. Another one, big ugly polyp there, massive polyp in the rectum, taken out in an unblocked fashion, defect there. So we can push the boundary. Now this is an extreme form of an ESD. So this is the case that I did a couple of months ago. And this is Barrett's. So you can see the pink and the white is the squamous. This Barrett's was bad. There was multifocal areas of high-grade dysplasia endoscopically in multifocal areas of cancer. So there's a lot of nodularity, and almost this entire Barrett's was diseased or dysplastic. So this required something a bit hardcore. And this was very difficult because this surgeon had a Nissen fundoplication. So the distal part of this esophagus was twisted because they wrapped the stomach. Even then, we can still achieve endoscopic resection. So this is the defect. Very scary looking, I acknowledge. Very scary to do. So that's normal mucosa here, the pink. That's where I started my resection, whatever you want to call it. That's the muscle layer with the inner circular fibers, and that's all resected. So essentially almost circumferential resection. We basically stripped this esophagus down, all the way down to the GOJ. There's the surgeon's clip from his Nissen fundoplication with those twisted muscle fibers. And basically, we've cored out this esophagus, taken off this mucosa and submucosal layers, and we've just left the muscularis propria. No perforation. Patient gets admitted overnight, gets on soft, I put the patient on fluids the next day, started a software diet the following day and discharged. No ICU, no issues. That's the specimen that comes out. Yes, difficult, and this is how we're pushing the boundary. But we didn't stop there. We've taken it even further. So we can resect the mucosa, we can resect the submucosa, and now we can even go into the muscle. So now there's a newish technique called an endoscopic intermuscular dissection. Now, not only do we cut your tumor out at the submucosa, we can cut between the muscle layers. So this is cutting between the inner circular and the outer longitudinal layer. Now, this is very, very fine work. So now, if a tumor is deeper in the submucosa, all the way abutting on the muscle, I can still take it out by taking the muscle. Or if it's going into the first layer of the muscle, I can still take it out. So here we essentially dissect between the two muscle layers, between the inner circular and the outer longitudinal. This is a very interesting case. This is an 85-year-old lady with Parkinson's, very comorbid. She had surgery galore. She had a right hemi for cancer. She had something done in the transverse. I don't know if it was benign polyps or if it was a cancer. She had a sigmoidectomy years later for again cancer. She's got Lynch syndrome. This is, clear. She's got 3 colorectal cancers and something in the endometrium. This is Lynch. She had now a scope for iron deficiency and GI symptoms, found a malignant polyp in the rectum. This lady would not tolerate a low anterior resection. She's not a surgical candidate. I was worried that this is deeper. When I assessed this thing with my optical diagnosis, I saw an area that's irregularly irregular. I'm worried about deeper cancer in this. So I gave her the best shot that I could by doing a deeper resection, and I did an endoscopic intermuscular dissection, and I'm going to show you that. Okay, so again, my optical diagnosis, looking for demarcated areas, assessing vascular patterns and all of that. I then take my knife and I mark I mark my boundary, so I know I'm going to cut nice and wide and get basically a good margin so we can cure this thing. So a nice wide marking. I take my needle, I inject some fluid into the submucosal space, and you can see how it expands. I lift it up beautifully. I then take my knife and I open a pocket. So I open this area here, and you'll see that now. So I take my knife, I open up a pocket here, I dig underneath the pocket to get underneath the tumor and dissect underneath. And that's how the knife cuts. Again, it's not, we call it a knife, but it's an electrosurgical knife. It's cautery. So in doing so, very little blood loss, and we can treat blood vessels and things quite beautifully. So I'm trying to get into the submucosal space here. Actually, I'm trying to get in this patient into the intermuscular space. So we're taking it one level deeper here. So here, I'm going to just freeze it so I can orientate you. That on the top, the pink is the mucosa. This is the submucosa. This is the inner circular layer of the muscle. And down there is the outer longitudinal layer. So what I've done is I was in the submucosa. Then I cut open the inner circular layer. And now I'm trying to find a plane between the two muscle layers. So you can see that muscle layer is thin. It's just a few muscle fibers, basically, but we can spare it. And I can cut very, very accurately in a very fine space. Of course, it does require technical skill and training, and this is more complex endoscopy and not everyday endoscopy. So let's just orientate you here again. Inner circular layer of muscle, outer longitudinal muscle. Inner circular layer running that way, outer circular muscle running this way. This is the plane that I'm dissecting in between the two layers. So you can see that muscle there, and you can see that muscle there, and that's my target. Okay, so after I dug underneath this lesion, so I made a pocket, I dug underneath the lesion, then I needed to come back up. So I needed to come back up out of the muscle into the submucosal plane and open up the mucosa and get above it. Again, you can see beautiful outer longitudinal inner circular muscle layer. And now you probably see me starting to come back into the submucosal plane. So now I'm cutting back up above the inner circular muscle layer to get back on top of the layers. So they're cutting the inner circular layer, getting back to my plane. I'm going to speed things a little bit ahead. Cutting that muscle layer, getting back into my plane. Scope flipped on itself. I'm opening up the back end of the polyp now. So I'm cutting open the mucosa on the back end. So I've made a pocket underneath it. I'm converting my pocket into a tunnel by coming out on the other end. Staying outside of my marks, so I get my R0 resection. And as I open up that back end, you can see my pocket underneath there. So again, you can see the top layer is the inner circular, and there's the outer longitudinal, and that's where I was dissecting underneath the thing. Let's speed up ahead, and that's the resection or the defect. And on the defect, you see outer longitudinal, thin layer of inner circular, which has been cut open, and that's the resection defect. This patient had a SM3 cancer, so it was deep in the SM, just touching the muscle. R0 resection. In theory, risk of lymph node metastasis of about 3%. In an 85-year-old with Parkinson's who needs a proctectomy, we will take the 3% very, very, very gladly. So if you thought we were going to stop there, we haven't. Because now we can take out the entire layers. I am going to stop there, but not endoscopically. So now we have devices that enable us to do full thickness resections. And we can take out, this is a GIST or submucosal lesion. It's under the mucosa. We open the mucosa, we see the muscle, we cut out the lesion, we make a hole in the stomach or perforation, and we just close the hole with clips. Another one, tumor, cut out the tumor, make a hole, suture it, close with the suturing device. Last video, it's not long, it's a minute, and then one more slide, and then we're done, I promise, before Jared kicks me out of here. Blaming Lyle, but he's the one that's complaining here. So I just want to show you that we can use clips to close things. And nowadays, believe it or not, when there's complications, it's great. The surgeons actually call us sometimes to fix their complications. So they do a scope, they close the perforation, and they call us to close it. This is just one type of clip and one type of technique, and it's just to give you an idea of how we can close things with clips through the scope. You don't have to take the scope out. We pass these clips through the channel of the scope, and we can effectively close things now. So first we were scared to make holes because holes meant perforation. Perforation meant bad outcomes. Perforation meant also calling your surgeon to bail you out. Your surgeon's going to shout at you. Your surgeon's going to say, why are you guys even trying these things? But now we're no more scared of holes because now we can close holes. And that is allowing us to push the boundary very, very far. Let's move on. So that's where we are in 2024. Last two slides, where are we going? Really, we have no limit to where we're going. And this, in my opinion, is really where we're going. Notes: natural orifice transluminal endoscopy surgery. We're now going to put the scope into your stomach. We're going to make a hole in your stomach. We're going to dissect your serosa. We're going to go to your gallbladder. We're going to take your gallbladder out. We're going to remove your gallbladder through your stomach, and we're going to close the hole in your stomach. We're going to make a hole in your colon and take out your appendix. There's transluminal nephrectomies that have been done through the vagina even. So these things are, yes, experimental, but this is the principle, and this is probably where we're going, minimally invasive. Surgeons are starting to hate us, but they're starting to acknowledge that this is better outcomes, and they're actually sending us their patients. Most of my patients that I get referred to me come from the surgeon. The surgeon will say, if you can take this out with the scope and I don't have to do a Whipple, please take it out with the scope. If you can't, I'll do the Whipple. So a lot of my patients are coming from surgeons. So this patient had a lymphangioma adjacent to the stomach. We diagnosed it with an EUS. We then opened up the stomach. We were now in the peritoneal cavity. We dissected out the tumor and we closed the hole with clips. So the abdomen and the mediastinum is becoming our oyster. Thank you. I hope I have shown you that gastroenterology has evolved, that we are no more just treating diarrhea, that we can do more. And I hope that I've done a bit to make gastroenterology great again in the mind of the physician.